In the cervical spine proper, having completed the biomechanical exam of craniovertebral joints, if that is appropriate, we can then come in and test these segments. We have somewhat of a more complex system in that we have the facet joints as well as the uncovertebral joints. Plus we have the discs to consider. So stability and mobility testing has to take these into account. We'll look first at stability testing, and we'll be testing anterior, posterior, transverse and again vertical stability at each of these segments. The first test we'll look at will be anterior stability testing. Now if we look at the bones, and I've had to flex the neck up considerably so it can be shown on the camera, and I certainly don't suggest you try and do this with your patients, you'll see that in order to stabilize the vertebra, my thumbs are on the anterior aspects of the inferior vertebra, in this case C5, while my fingers are on the neural part of C4. Now, this test isn't nearly as brutal as it sounds, providing you take one or two safeguards. The thumbs go underneath the sternomastoid, not over them. Also, the thumbs actually don't produce very much in the way of a shearing force. They are there simply to stabilize. So in this position, I will stabilize C5 in this case, and I will draw C4 forwards by pushing forwards with my fingers, my index fingers. To reverse this test for a posterior stability test, I simply reverse the position of my thumbs and fingers. So I will move the thumbs up to the superior process and my fingers to the segment or the bone below. And again, simply stabilize with the thumb, and this time we'll push the inferior vertebra forwards, thereby inducing a relative posterior shear through the segment. Let's see what this looks like on the patient. The thumbs will reach underneath the sternomastoid and not over them, and they will lay on the anterior aspect of the transverse process of the inferior bone of the segment. The index fingers will come over the neural arch of the superior bone of the segment, and then keeping my thumb still, I will push the superior bone forwards on the stabilized inferior bone. And any movement that does occur will simply be due to the resilience of the disc, rather than as a slippage in an anterior direction. And this is what you're looking for, is an anterior slip or a click as you do so. For posterior, I'll simply reverse the position of my fingers. They'll go from the thumbs being on the inferior vertebra to coming onto the superior, while the fingers will move down onto the inferior vertebra. So again, underneath the sternomastoid with the thumbs onto the anterior aspect of the transverse process, while the fingers go on the neural aspect of the inferior process, and then they will again push forwards. And done this way, these tests are not terribly tender. Isn't that true? No. And I'm paying her to say yes. From this, we should be able to say whether we have an anterior or a posterior instability. You can't really say what tissues are at fault, simply that you have a directional instability. For the transverse stability testing, it's very, very similar to the way we did it in the craniovertebral joints. And just looking at the bones, the padded part of the metacarpophalangeal joint here will go onto the transverse process of the superior vertebra, while on the other side will be on the transverse process and neural arch of the inferior vertebra. So in this position, if I can flex the neck up so you can see where it's going, we'll have one MCP sitting there, while the other one is sitting there. And then we shall simply shear them across each other and then reverse the direction. This test tends to be a lot more stable in the upper cervical spine because of the more developed uncinate processes. So coming back onto the model again, we'll be in this position and simply shear them across each other. And you'll move down the neck as you test each segment, and don't forget to reverse the direction of the test like so. And again, you cannot be specific as to the tissue that's allowing the instability to occur, but just simply the direction of the instability. Vertical instabilities occur when there is severe degeneration of the segment, where the disc has become degraded and the facet joints are so degenerate that telescoping occurs due to the severe narrowing of the disc. To test this, we will do alternate compression and distraction at each segment, looking for excessive movement and also clicking. In order to accomplish this, we will need two grips, one around the neural arch of the inferior vertebra, again a nice wide grip, while the superior hand will come across the neural arch of the superior vertebra, and then we will compress and distract each segment as we test. So, how does it look on the patient? This position should be fairly familiar to you now. It's a position that we used a good deal on the craniovertebral joint, so there shouldn't be any trouble bringing it down into the neck. So, a wide pinch grip around the inferior vertebra and a wide pinch grip around the superior vertebra here. And again, tuck your chest and shoulder over the top of the head, and then compress and distract and compress. And we'll repeat that for each segment. Looking for an excessive amount of movement and or a consistent click as we do this.